Dear colleagues, in partnership with the Österreichische Gesellschaft für Nephrologie, the Deutsche Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Transplantation and Dialyse, Marcus at Home welcomes Dr. Butler in Jackson, Mississippi, in order to discuss whether to use or not to use SGLT-2 inhibitors in patients after acute myocardial infarction. Dear Dr. Butler, it's a privilege to host you tonight. Thanks for being with us.
Absolutely, my pleasure. Thank you for inviting me.
Thank you very much for coming. Just as a short introduction, Dr. Butler is currently president of the Baylor Scott and White Research Institute and also distinguished professor of medicine at the University of Mississippi in Jackson. And he has an outstanding track record on publications and large trials, and also an academic track record of his universities. He's been affiliated with names such as Yale, Vanderbilt, next to an MD, also having a Master of Public Health from Harvard, an MBA also from the Emory University. And the reason he's here today is he's senior and lead author of the EMPACT-MI trial on Empagliflozin in the setting of acute myocardial infarction. We're very keen on hearing your insights into that study and hopefully also having some time to discuss that. So if you please share your thoughts and information on that study with us. And thank you very much again for coming.
Yeah, absolutely. No, I very much appreciate the opportunity to talk to you. And it also gives us some opportunity for me to give you my interpretation and not only the results, but that will lead to a good discussion. Maybe you'll agree with my interpretation, maybe you won't. So that'll be great. This is the presentation I gave at the ACC. These results are all published. But as I said, that I will liberally give some editorial comments as I give this presentation. These are my disclosures. So we will dispense with the background slide. Everybody knows here that SGLT2 inhibitors have been shown to improve outcomes in high-risk patients, CKD, type 2 diabetes, also in patients with heart failure, regardless whether you have HFrEF or HFpEF. Now, what is interesting is a couple of things to sort of just keep in mind. One is that we have seen a sea change in the management of acute myocardial infarction and acute coronary interventions over the past 2 decades or so. When I was a cardiology fellow, and I'm talking about the mid to late 1990s, streptokinase was the way we treated myocardial infarction. TPA was the big thing, was gusto, and routine angioplasty was not available. And from there on, now it's amazing that even the rural hospitals all have the network that either there is a cath lab where you have the door-to-balloon 90-minute thing, or there are referral patterns where patients are diverted to for an angioplasty and revascularization. On top of that, you have stents and dual antiplatelet and anticoagulants and statin therapies and all those kind of stuff. So all that is focused on reducing the recurrent coronary events. But the last time we had any innovation to improve myocardial outcomes post-heart myocardial infarction was 20 years ago, was the Ephesus trial. Since then, we have had no therapy to reduce the risk of heart failure in these patients. So that's one comment that I will make. The second comment I will make is that I find it really fascinating to have lived through this era in cardiology, that when I was a cardiology trainee, patients with STEMI had much worse prognosis than patients with non-STEMI. You had this heart attack, you got streptokinase, 10 hours into MI and all that kind of stuff, and arrhythmias and heart failure, whatnot. Now, these STEMI patients, they come in and, many of them actually go home within 36 hours, like overnight, and they go home the next day, they get their angioplasty. So if you look at the epidemiologic data, 3/4 of heart attacks or AMIs are non-STEMI, 1/4 is a STEMI, and non-STEMI actually have worse outcomes for recurrent events than STEMIs because of multivessel disease and comorbidity burden. So all of these points will become important when we interpret the results, but just keep these introductory comments in mind. Okay. So with that, the EMPACT-MI, was designed to answer the question whether there is improvement in clinical outcomes when empagliflozin was given to patients in the acute myocardial infarction setting. Now, what we forget is that everybody has belief that SGLT2 inhibitors are safe. At this point, nobody has to prove the safety of SGLT2 inhibitors, but I would say that was a big concern for us. And the reason it was a big concern, at least for me, like every time we had a data safety monitoring board, I was just like waiting to see if something they say that is a problem. Because remember, these people have acute MI, hemodynamic instability, 90% got revascularized. So heavy contrast exposure, IV contrast, angioplasty, and then simultaneous initiation, possibly of RAS inhibitor, MRA, and an SGLT2 inhibitor. This is different than addition of SGLT2 inhibitor in the chronic setting, right? So I had actually a lot of concerns about safety, and then obviously the clinical efficacy. Now, the problem was, I shouldn't say as a problem, the world is moving towards this whole notion of pragmatic trials, right? We need to decrease the burden on the sites, and we need to decrease the burden on the patients, and we need to make the trials more cost effective. Point very well taken. But when you make things pragmatic, there are some sort of trade-offs that you need to do. So in this trial, the trade-offs that we did, some of them were wholly good. So for instance, our inclusion-exclusion criteria were just very generic. Like you didn't have to do any special test or any special biomarker, whatever it is, you're coming in if you had an MI within 14 days. We had almost entirely follow-up was remote. We had one inpatient visit. That's it. Everything was remote. There was no follow-up physical examination. There were no follow-up lab tests, nothing. All remote, phone, web, tele. Very streamlined data collection, not those reams and reams of CRF. But the fourth part is the most important, and that is we did not have a clinical events committee. So we trained the sites, and whatever they said, it goes. So in US, at least, the regulators are totally on board of not having any clinical events committee. Now, the problem is that mortality, there is no controversy. If somebody is not alive, they're not alive. But cause of death, there is some controversy for CEC versus the sites. And then the second thing is that hospitalization for heart failure, the overlap, and these are all published data, the overlap between CEC versus site adjudication is 90+%. If it's heart failure hospitalization, it's heart failure hospitalization. But outpatient heart failure, it's about 50%. There's a lot of disagreement. Because we did not have a CEC, our endpoint was time to first all-cause mortality or heart failure hospitalization. We made two compromises here, right at the bat. All-cause mortality, we know that 20-25% of the mortality is going to be non-cardiovascular, right? So SGLT2 inhibitor is not going to reduce mortality from cancers and accidents or whatever. So that was a built-in problem. The second is that we did not have outpatient heart failure in our endpoint, but we made a calculated risk, and I'll tell you in a second that risk just did not work out, unfortunately. But the calculated risk was that looking at the past data, about 5 to 10% of the events are outpatient heart failure. So we said, okay, fine, so we'll have a little bit of less power, but this way the trial will be very pragmatic. So just keep that in mind. It's all-cause mortality or heart failure hospitalization, not causes specific. Every cardiovascular trial right now that is being done has cardiovascular mortality as primary endpoint, but we had all-cause mortality, and outpatient heart failure was not part of the endpoint. So these were STEMI, non-STEMI patient within the past 14 days, some enrichment. So they either had congestion, even with totally normal EF, or a new drop in EF to less than 45%. If you had history of heart failure, you were excluded. You could not come into the trial. So we were focusing on new onset heart failure overall. Global trial, multiple countries, 6,500 patients that were followed for this primary endpoint. Patient population. So here's the first thing to note. At the top of the slide is the patients who came in because of congestion or because of LVEF or because of both. 75% men, 31% type 2 diabetes, 13% with prior MI, 0% with prior heart failure. That was an exclusion criteria. But the first thing to note here, every single registry tells us that 3/4 of MI is non-STEMI. Every trial with MI, 3/4 are STEMI because of the patients that, we saw the same thing in Paradise MI with valsartan sacubitril. 75% were STEMI patients. So there's this inversion of epidemiology in clinical trials. because we go for, MI site investigators. They're all cath lab. Their nurses are in the cath lab. So just keep that in mind. That will become important as well. Unbelievably well-treated group of patients at the baseline. So whatever benefit we are going to see in heart failure outcome is on top of 80+% RAS and beta blocker use, close to 50% MRA use, which is also quite high, 95+% antiplatelet and statin therapy, and almost 90% of the patients got revascularized. So really, really well-treated group of patients. Okay, so this is the primary endpoint. Few things to note. So one, obviously, we did not hit the primary endpoint, hazard ratio of 0.9, p-value of 0.21. One thing to note is that look at the direction of the 95% confidence interval, right? 0.76 to 1.06. So if you are a Bayesian, which I am, it's already sort of leaning more towards this side, but that side. But we'll talk a lot about it in a second. The second thing to note is that as opposed to any SGLT2 inhibitor trial, all of which showed an early separation of the curve, we got nothing happening for the first 120, 180 days, and the curve starts separating late in the trial. This is distinctly different than any SGLT2 inhibitor trial. So that tells us basically that whatever the benefit is of empagliflozin, acute MI-related issues, stent thrombosis, septal ruptures, whatever happens in the acute phase, that's where SGLT2 inhibitors are not going to benefit per se. A bunch of secondary endpoints that all had all-cause mortality were not positive, except that there was a 1 p-value of 0.04, but really nothing to write home about that either. But now here is the interesting part. No impact on all-cause mortality, but look at the benefit on heart failure hospitalization. 23% relative risk reduction. And honestly, if on this slide, if I were to take out all the letters, words, and numbers and just show you the Kaplan-Meier curve, you wouldn't know whether this is EMPEROR-reduced, EMPEROR-preserved, EMPACT, EMPA-REG outcomes trial, right? Early separation of the curve, 20-25% relative risk reduction. So if you're a frequentist, you will say, Dr. Butler, you're just making this up. Your primary endpoint is negative, the trial is negative. If you're a Bayesian, you'll say, well, this is something we have seen in every single trial, and you're seeing the statistically significant 23% relative risk reduction. And then if you look at the total heart failure hospitalization, first and recurrent, there's a saying in clinical trials, and I'm sure you have heard it before, that if you need a p-value to make your point, maybe your data are not very strong. I mean, look, here the p-value is very significant. The benefit is even further exaggerated to 33% relative risk reduction, very early separation of the curve, wide separation. So one question that you may ask is that, look, if heart failure is such a high-risk feature for mortality, why is this heart failure prevention not translating into mortality benefit in your trial? And the problem is that that's not the study, unfortunately, we did. There were about, on average, people developed heart failure at about 3 months or so. But then it took, the follow-up after that was less than a year. We just did not have enough events in these patients to show the difference. There were only 53 deaths in these patients, and it was just not enough. Now, the other thing that really came to bite us, and I'll go back on 2 slides here to show this. If you and I were sitting in a cafe designing this trial, and if I were to ask you that this trial is powered to have 550 events, how many do you think will be heart attacks? I mean, how many do you think will be mortality events versus how many do you think will heart failure events? I don't know what percentage you will give me, but the rational explanation will be that there will be more heart failure than deaths. There's just no rational explanation that more people will die. The problem is that we have this distortion because we did not include outpatient heart failure, so the proportion changed for this reason. This trial was designed in 2019, and we thought that we are going to let go of 5% heart failure outpatient, right? Sure, the world is trying to treat more outpatient heart failure, not inpatient. Okay, fine, that's the compromise we made. What happened in 2020? COVID. So the first 2.5 years of the trial was solid in the COVID phase, and there's lots of published literature that the heart failure hospitalizations went down dramatically. The second thing, 2 of our regions which were very active in the trial, Russia, Georgia, and Israel, high enrollment rates, global wars. COVID, I have data to show you that hospitalizations went down. Impact of wars on hospitalization, I have no idea. But again, it's reasonable to think that it's not the same degree of care that the way we were getting. So the bottom line is that we had actually more death events than heart failure events, which is pretty unusual. You would not predict that. And then not only were there more death events, out of those deaths, we are doing all-cause mortality, and about 20-25% is not modifiable. Okay. But here's the deal. The deal is that we don't have outpatient heart failure in our primary endpoint, but we did collect data on outpatient heart failure. So by now, if I'm sounding completely defensive to you, let me continue that trend. So here's our data. If we include outpatient heart failure, now we have a 37% relative risk reduction in heart failure. And if we actually go back and just make up an endpoint, which is the original endpoint of what it would have been, which is all-cause mortality and heart failure hospitalization, there was a 21% relative risk reduction that reached statistical significance. And then if we focus on only heart failure death, it is shown at the bottom, that was also statistically significantly different. So then the question is, okay, fine, you're sort of making up all of these things. These are all exploratory. We don't believe you. Can you give us some confirmatory support? So we said those patients that were not discharged on heart failure medications, within the first 6 months post-discharge, if somebody got started on heart failure medication, it is an indirect support of this outpatient heart failure. The new use of ARNI, new use of MRA, new use of any RAS inhibitor, new use of diuretics, all of them, 25% higher chance of being started in the placebo arm than empagliflozin arm. So again, supportive evidence that the outpatient heart failure data probably is true. Very safe, no adverse renal events or something like that. We will publish a full paper on this. So the bottom line is that if you're a Bayesian, remember that the p-value is for EMPACT-MI, not for the endpoint. If you're Bayesian and look at all the data, so we did publish this in Lancet Diabetes Endocrinology, all SGLT2 inhibitor trials, diabetes, kidney, REF, PEF, and including the 2 MI trials. And the EMPACT-MI results are exactly in line for heart failure that we have seen with any other trial that we have seen in the past. So at least my Bayesian interpretation is that in acute MI, we did not reduce mortality, we prevented heart failure, that all of these other trial considerations did impact on the primary endpoint, and that the details, we sort of worked quite hard to get published all of these details. Primary endpoint got published, all of these nuances of outpatient heart failure got published. We also published a paper on enrolling EF and enrollment congestion criteria, and then this meta-analysis. So I'll stop here. Thank you for inviting me, and I'm very delighted to answer any questions.
Well, thank you. This was really fascinating and also convincing. Obviously, that was your intention, I'm sure. Well, the first question that comes to everybody's mind is obviously a few months earlier we had a similar trial with the other drug, slightly different patient population. Maybe you can allude to that. That was really completely neutral. I mean, DAPA-MI. If we look at the win ratios there, I just looked it up again, and the hazard ratio for heart failure hospitalization was 1.01. So it's completely neutral in that respect. Why is that the case, and why is the difference so big with empagliflozin? Is it just a different patient population, more heart failure?
Yeah. So I would say that what you are alluding to is not exactly true. So DAPA-MI, first of all, there were enrollment issues or endpoint ascertainment issues in terms of the number of events that they were getting. So the trial pretty much was stopped way prematurely. So there was a 7-point win ratio that was looked at. The data that you described is for the win ratio component of heart failure. They only had about 70 heart failure events. And if you can see my slide and my cursor at DAPA-MI, if you look at all heart failure, there was about a 17% relative risk reduction going in the right direction. Only 70 events. So I would say that DAPA-MI was completely non-conclusive, was not neutral or negative, non-conclusive. And again, I am a through and through Bayesian. So if you look at this 18% relative risk reduction with 70 events, I think if the trial would have gone to conclusion, they would have had very similar results to ours.
That's a clear statement. I have another technical or easy to answer question. When was the inclusion and the randomization? That you alluded to the fact that the curves didn't separate very early, but the drug was given so early. What was the average starting point of
Day 5 on average?
Day 5. So actually acute decongestion, and you showed the less amount of diuretics, that in your interpretation didn't make the difference, did it?
I don't think so. So, I mean, I think that at the end of the day, the predominant, STEMI patients that came in probably had a lot of stunned myocardium, maybe some early congestion, revascularization, that just sort of took care of it. But the remodeling post-MI and myopathy process, whether it is REF or PAF, that took several weeks to months. And then for the therapy to work and show the curve separating, that took several months, not acutely. And all the acute events were probably, and we need to look at that data, and that's sort of a project ongoing, but all the acute events were probably all related to either vascular or mechanical or other complications of MI, which are just not amenable to SGLT2 inhibitors.
Your presentation was highly convincing, and I have just a single question. So it looks really as if the curves diverge the longer the follow-up becomes, and surely follow-up, as in many randomized clinical trials, is limited to 2 to 3 years. So are you planning any long-term follow-up, like legacy data, to see how the patients will end after 5 years or so?
I wish. So first of all, I wish we had the 2 to 3 year follow-up. Even with all the things that I've tried to convince you about, pragmatic trial and all-cause mortality, even then we would have had a positive trial. I think the average follow-up was 17.9 months, so shy of a year and a half, and post-heart failure was less than a year. So I wish we had a 2.5 year follow-up. No, I mean, that's part and parcel of sort of the pragmatic trial. There is no post-randomization registry or follow-up, so unfortunately we will have no data.
Just to understand you maybe more clearly, as a true Bayesian, what would have been the ideal trial design? Would it have been an adaptive trial? I'm just asking from the nephrology side, to get faster to the endpoint with fewer patients.
Well, that's a possibility, but I don't think that the world is sort of ready for that just yet. Or at least for a new indication. So yes, that would make sense, but we're not there yet. But I think in retrospect, if I were to do something different for the trial, I would probably just go for very traditional cardiovascular mortality and all heart failure events. And that would necessitate a clinical events committee and adjudication and sort of the way we traditionally do trials. And if we would have done that, the trial would be positive. I think it's pretty fascinating, right? That I'm really honored that the European Society of Cardiology, HFA, has requested me to give the Lifetime Achievement Award Brown-Wall lecture. And what I talk about is that our role as clinical trialists should be to find the truth and not prove the hypothesis. I think that's a fundamental flaw in the way we do science, that we prove or disprove hypothesis. That is good for basic scientists, and that is good for physicists and astronomers. But when we talk about human beings and medicine, all we need to do, I think, in my mind, is just find out what the truth is. Finding what we will conclude from EMPACT-MI is that you could not prove the hypothesis that it improves this particular endpoint in this particular trial. That is very dissatisfying to a clinician. The truth is, what did you find in the result, and how does that impact your treatment? And I think that focus is missing in clinical trialist world.
Marcus, since you reminded us of being a nephrologist, the two of us, so I have a second question, sorry. You actually saw less acute kidney injury and less acute kidney failure in patients who received the SGLT2 inhibitors. And this has been shown in earlier trials, as I'm aware, but this is still kind of funny for us because with renin-angiotensin inhibitors, we always see an increase in these events. Do you have any idea, or will you present other data in the not too far future on that?
Yeah, so it was comparable. Numerically, yes, very sharp of you to notice that. Numerically, a little bit on the lower side. So we are going to try to get into a late-breaking update at ESC if they select us or not. But definitely around that time, we'll have a full paper, because I think this is pretty fascinating to see what are the subgroup differences. I mean, getting IV contrast, the degree of revascularization, one vessel, more than one vessel, whether it is percutaneous versus surgical revascularization, and how many of the reno-active medication, RAS inhibitor, MRA, and SGLT2 inhibitor were started simultaneously, and whether there are any differences. So the top line is that there is no problem, but I think we need to understand the subgroups a little bit better before we push this message too hard. So that's the plan for ESC.
So one thing is trial design, and you mentioned that very exactly. The other is, as you said, is treating the patients. What's your interpretation? What's the ideal patient that would benefit from an SGLT2 inhibitor? Because the inclusion criteria, ejection fraction is okay, but congested patient, that's a little bit soft. I mean, what do you think? Is it a high NT-proBNP? Is it really pulmonary edema? What patient in your thought should be treated and would benefit most?
So I'll make up an answer because that's the way I'm looking at the data, but stay tuned. We are doing at least 2 papers specifically to answer this question. So create a sort of a degree of risk profile and which patients are at the highest risk of developing heart failure, what is the absolute risk reduction, number needed to treat, NT-proBNP at baseline, all of that is coming. But today, if you were to ask me this question, I would look at it in 3 steps. So step 1, if somebody comes in with acute MI and they have any indication for SGLT2 inhibitors, but for whatever reason, they are not on it, they have diabetes, they have heart failure, they have CKD, you should feel very safe of initiating in an acute MI hospitalization based on our safety data. Forget about MI just for those reasons. So that's step 1. Step 2, if somebody does not have any other reason to be on an SGLT2 inhibitor, just came in with an MI. In the interest of time, I didn't show you the data. It's published in the New England Journal paper. Non-STEMI patient had a much higher benefit than the STEMI patients. STEMI patient, the hazard ratio was like 0.93 or something, and non-STEMI was 0.77. And that makes total sense to me, that non-STEMI with the cardiometabolic milieu, multiple disease. So I would be very aggressive in treating non-STEMI patients early. If somebody comes in with a STEMI and they get revascularized in the acute phase, I don't feel very compelled to start them on an SGLT2 inhibitor in the absence of any other indication. And let's see how they do. Stunned myocardium is gone. They're doing great. Maybe they'll just do great. But now you have revascularized, and 10 days later, they still have some edema. They still have short of breath. They're sort of in that transition phase. That patient should be started. That's the way at least I'm interpreting the results.
Well, this is fascinating, really, again, and we're so happy also, especially for these editorial comments and interpretations and kind of maybe some openings and making us more curious about all your work still to come. Thank you very much again for giving this presentation, for interpreting the data, and thank you for your great work. We're looking forward to more of that, and thank you.
Really appreciate being asked to talk to you today.